questions. So thank you very much for all the questions we received, many of them. Unfortunately, we don't have time to answer all the questions, but of course, we have time for 2 questions per speaker. So we would like to start with Dominic.
So here comes the first question, Dominic. So we were wondering, or some of the listeners were wondering, what you use as a default setting in the CABG patients, and how do you assess the response to hyperoxia? And the third part, what do you think about special situations like COPD or pulmonary hypertension?
Okay, let's start with the default setting. That's actually not that easy to answer. First of all, the data has to go through stringent peer review before we should apply them. But I can tell you what I do in my own practice. When I see that a ventricle does not pump well, I usually tend to give it more oxygen. The correct thing, looking at our data, would be try and error. So you look at both. You look at hyperoxia and normoxemia, or at least look at normoxemia and then decide based on our data. But very often there is no time for that before going on bypass. So at the moment, I do it just visually. If I see a bad LVEF, bad strain, I give them more oxygen and less oxygen if they pump well. Of course, in the future, we need to establish something much quicker and much better, preferably pre-op, that we say, okay, this patient has this preoperative echo findings, and this is the appropriate setting for this patient. This is, I think, where we should go to. Then how do we assess hyperoxia? I mean, in that study, we did it with echo and strain. Does that answer your question? And then what do we do if we have pulmonary arterial hypertension? So our findings concerning the RV really astonished me, because if I see a RV that's not pumping well, I usually increase oxygen in order to reduce afterload, because the RV is much more sensitive to increase of afterload than the LV. So my goal would be to have the pH in the BJ lifted to reduce PaCO2, and also to increase oxygen to get less stress on the RV. However, there seems to be competing effects that we weren't like that well aware of. Is that we, on the one side, we make it easier for the RV to pump by reducing afterload, but we have that effect of hyperoxia being a coronary vasoconstrictor who can reduce perfusion to the RV. So this is a bit of a conflict, really. At the moment, I don't really have a suggestion. Whenever I see RV that pumps better, increase oxygen. Unfortunately, we don't have the appropriate amount of patients that had PHT to really assess what in patients with pulmonary arterial hypertension and CAD, what the best setting for those is. But I guess that could trigger its own future study looking at that.
Dominic, one additional question. What about MRI? So you did many studies with MRI assessing the response to oxygen. Is MRI a future possibility to be used in critical patients to assess the response to oxygen?
Well, as much as I love MRI as a tool, as a research tool for me, MRI is never a tool for a critical patient, because the exam takes too long and you don't have the means to respond if there is an emergency in there, like resuscitation. You cannot roll a defibrillator in there. So in my opinion, MRI is never a tool for a critical patient. On the other hand, we're starting a study where we actually try to induce general anesthesia in the MRI and measure the effects to myocardial oxygenation. It's a very ambitious study, and we're just getting the first results on there, but I cannot tell you that much at the moment.
Okay, thank you very much. So Anja, are you ready for your questions? Okay, some of the participants asked about the flow increase. So do you increase the cerebral flow if everything is cannulated? So normally you have a certain flow for the cannulation for the right side, but if the left side has been cannulated, do you normally increase the cerebral blood flow? Is it an adaptation of blood flow?
I'm happy that you answered the question. I showed this in my picture, but I actually skipped and didn't mention that you actually have to increase blood flow in your antegrade cerebral perfusion lines. I'm very happy you said, do you increase cerebral blood flow? Well, I don't know, because I don't know how much goes into the cerebrum and how much into the brain and how much goes into the arms. But maybe you saw the little numbers when we cannulate the subclavian artery on the right side and do two separate lines into the subclavian artery on the left side and the carotid artery on the left side, then we will target a much higher flow of 1 liter over the main pump that is perfusing in the subclavian artery when the truncus brachiocephalicus is clamped. And an additional 600 to 800, it depends on the pressure they measure, over the 2 lines going into the left subclavian artery and the left carotid artery. Mm-hmm. So this will be about 1.5 liter, actually, yeah.
So you mentioned you use 1 liter for cerebral blood flow. Sorry. So overall, you are using 1 liter flow, and some centers are using 8 or 10 liters. 10 milliliters per kilogram per minute. How do you assess the quality of the flow? When it's time to increase or decrease the flow? How do you think about?
I think there is
kind of monitoring do you use to assess the quality of your cerebral blood flow?
As I said, there are different monitor possibilities, but you have to aware what you monitor with which device and what is your black box. In the end, our goal is to match flow, to provide the flow that matches oxygen demand. And we don't actually know it, and it depends on your temperature, on your metabolic rate, and for sure, once if you have a monitor device that shows you that something is wrong, such as NIRS value going down on one side, or EEG, once you're hypothermic, the EEG is difficult or will be affected as well. But if you have a sign that something is wrong, either clinically, that like one side of the patient gets white and the other one red, or the NIRS value goes down, or the pressure doesn't match the flow that you would think that has to result, then you have to check all your variables and to try to optimize them. But you have to be aware that there is a black box, especially in the posterior area of the brain.
2 small questions. Do you see a role for transcranial Doppler to get even a better insight in your cerebral perfusion? This would be the first part of the question. The second part, what's about the fraction of inspired oxygen was one question from the participants. Is there any possibility to adjust it to get a better cerebral blood flow?
First part of the question about the transcranial Doppler, me personally, I'm very interested in this device, but there is at the moment no at our center, and from the survey done in Europe in 2015, in most centers they do not use transcranial Doppler as a routine monitor device, because you have to be able to, first, not all patients have a window that allows you to get the flow, to get the signal. And then you have to fix it, and you have to keep it in place, and you have to know the technique and be able to interpret the changes, and this is just not in routine use for us. And Moreover, this again, it just shows you velocity in the middle cerebral arteries is still not, it still doesn't prove that this is actually adequate or that it actually really reflects flow. But this is one question that we are going to have a closer look at in the very near future, Gabor.
What about the fraction of inspired oxygen? Is there any possibility to even increase the cerebral blood flow by increasing the fraction of inspiratory oxygen during cerebral perfusion? Do we know something about this?
I am actually not aware of higher oxygen increasing flow. We have a very close look at CO2. If we have hyperventilation and the CO2 goes down and we have vasoconstriction, this is something we do not want. Increasing oxygen content in the blood, I think when we have the possibility of an oxygenator, I'm not sure this will, if flow is limited, if the supply is limited by limited flow, then you can put as much oxygen into it as you want. It's not gonna help anything. If you do this calculation of how much more you can, you have to put it in a hyperbar environment to have an effect of this.
So adequate placement of the perfusion catheters and PCO2 would be more important than FiO2.
I have no data to prove this, but I think so. Yeah.
Okay. Thank you very much.
If I may add to that, it's known that hyperoxides or vasoconstrict in the brain too.
Yeah. Thank you, Dominic. Okay.
Daniel, are you there? So we have some questions for you.
I'm here, yeah.
So I know you already mentioned your triggers that you use besides the hemoglobin value, and there was a question: what do you think about the patient's age? If you have a cutoff there, and if you wait for the TRIGS-4 trial, what do you have to say to that question?
Well, I personally usually aim for a restrictive regimen, but do some adaptations in there. As I've shown, hemoglobin is not the only thing we should consider. And a patient with a young age, we don't have the data yet, but me personally, I'm a bit more in favor of adding a transfusion if the patient is of young age and not 65 or older. But I don't have any data on this, and this is just my personal way of doing it, as we have no fixed structure how to do this in our house here.
Mm-hmm.
And there's the question: how do you handle a patient with chronic versus acute anemia? Do you have
I think here these data that I've shown with the decrease of the pre-op level come in place. Patients that start low with maybe hemoglobin value of 9 grams per deciliters and go down to 6.5 gram per deciliters probably will tolerate that as they have some adaptation and to this already low pre-op levels. And I think here it's important to look at other parameters as lactate levels, oxygen balance, if you're able to measure it, that can help you guiding your transfusions in there, because usually these patients are not well reflected in these randomized trials. And if you look at all these retrospective data, usually you see that transfusion is bad. If you have more transfusions, you have a worse outcome. But even with all the propensity matching that is usually done, I have my doubts whether in this retrospective way of looking at transfusion, maybe it's more a quality measure and not that much a outcome defining thing in these studies.
Okay, thank you. So I think we have to hurry a little bit.
One question for you. What do you think about MitraClip? Could MitraClip an option in your patient?
I think according to the guidelines, a transcatheter edge-to-edge repair is an option for patients which are judged not appropriate for surgery. And in our case, the patient is already in the operating theater, the thorax is open. I think it's no option for this patient. She's also, needs to be said, she's very young. And once you place the mitral clip, you have no surgical possibility to fix it in a mitral valve repair. So I think for this patient, it's not an option. Okay. The patient was 65 and the EF, the ejection fracture is 20, then of course it's another situation.
Mm-hmm. But how do you deal with unexpected findings in the OR? It is the responsibility of the anesthetist to inform the surgeon about unexpected findings, or it is a team discussion, or even should we call the cardiologist to help us in case of an unexpected finding?
I definitely think that it's a team decision. What we can do is we can really demonstrate the surgeons our findings, and often the surgeons also ask us, what do you think? Should we replace the valve, or what do you think? These questions often come. What we can do is that we can always ask one of our colleagues, or even like you said, ask some specialists from the cardiology department. The thing is, this service we don't have 24/7, and our case took place late in the evening, where you are the only cardiovascular anesthetist in house, and to get a second opinion in a good period of time is more difficult during that evening time, and not 9 to 5 times. So that's a bit difficult, but whenever possible and you're unsure, I think you should always get a second opinion, whether it's a colleague or a cardiologist.
So thank you for this clear comment, Trevor.